we are able to see people have aggression and violence. Then also in postpartum or puerperal psychosis, these mothers also are likely to possess these psychiatric images which are called aggression and violence, and sometimes is also in catatonic excitement, where someone is too happy, excessively, which we are calling catatonic excitement. In those people, we are likely to see that they are going to have aggression and violence. Okay. So furthermore, we are going to look at the causes of aggression and violence. What is likely to cause the aggression and violence? Among the many things, one of them is hallucinations. This is a disorder in perception, which are many. Hallucination, the patient may see animals which must be fought or which he wants to fight. Remember, I asked you to talk about the disorders of perception. And here in perception, I expected you to talk about hallucinations, the different types of hallucination, auditory, olfactory, gustatory, visual, tactile hallucination. So we are saying one cause of violence, it's because the patient is seeing animals that he must fight, and that is a visual hallucination. And that's one cause of aggression and violence. Then you talk about delusions, and in delusions, you are going to find that the patient has a certain belief. In delusion, the patient has a certain belief that things are not going on well, or people are insulting him. And this is a false belief. Patient may realize that his fellow patients or staffs have been sent to insult him, especially the patient with grandeur delusion. As we talked about the general symptomatology, grandeur delusion, this is when a person has feelings of being the most important or high, or is taken to be the most valuable person. And those are false beliefs can tell you that I'm the president, I'm the king here, and yet it is not true. So someone who has such a grandeur delusions will believe that other patients or staffs have been sent to insult him or her. So that, and eventually he will become aggressive and ends up becoming violent. So the cause would be delusion. Then we have provocation of others. When someone is provoked by others, people come to disturb him, which we are calling provocation. So once they disturb him, then he's going to react to the disturbance by becoming violent, so that he can gain his position or in wanting to respond to what they are doing to him. Then we talk about denial of trial. When the patient is denied for trial leave or discharge. Remember, this is a patient like others. So he will want also to be discharged as he's seeing other patients being discharged. And you as a health worker, you will deny him not to be discharged or to go for a trial leave. And in so doing, he's going to become angry. And we are saying that feeling of anger, we are calling it aggression, that eventually makes this person to become violent. Then there is another cause, which is alcohol and drug abuse. Remember, it affects the nervous system. Once someone has taken alcohol, he's not able to reason out very well. So he will perceive even hallucinations because of the alcohol or the drug of abuse. and he will be commanded to act in a certain way that may not be normal. Then there is a point of forced admission. Client has a certain mental condition. To him, his feeling is not having it. For example, has no insight about that condition. But for you are saying he should be admitted. So that forced admission will make the client to start quarreling, will make the client to start becoming aggressive, and hence will become violent and will start hitting people. Then we can look at another cause, which is poor diet or delayed meals. When they are not being fed well, the patients may react badly, which you are saying aggression, because they are not fed well. Or the meals delayed. They know that they have to eat in the morning, they have to eat lunch and supper. Now breakfast is brought at 10 when it normally comes at 8. Lunch is brought at 2, yet comes at 1. So those delayed meals or poor diet will eventually make the client or the patient to become aggressive and eventually will be violent. Then we talk about the point of institutionalization or forced discharge. The client still wants to be in the hospital. It is rare, but it does happen that the client may want to be in the hospital. And if he's denied the chance, then he's going to react. And the reaction is the one you're saying he is going to be violent and aggressive. Then there is poor nurse-patient relationship. The health worker is not in good terms with the patient. And in so doing, the patient is going to become aggressive. Either maybe the health worker is using abusive language, and this irritates the patient, and the patient will become aggressive and eventually become violent. Then you are talking about nursing a calm patient with disturbed ones. It's another cause of aggression and violence. If you happen to be having a patient who's calm, it's not. We are saying nursing a calm patient. Nursing a calm patient is an aggressive one. We are saying it is not good in that once you are nursing a calm patient is an aggressive one, then this one is going to start quarreling as the other patients will start quarreling as the other patient make for him or her noise. Then also looking at we are looking at how we are going to manage this client, who has aggression and violence. What are we going to do? And one of the things is to ensure that we are saying a calm, interested approach is very important. Remember the principles of yesterday, that we need not to panic, because panic makes the client, relatives, and the patient more worried. So we are saying you have to be calm as you are managing this aggression and violence, and we use a calm approach. That is one thing we are going to do as we manage this person who has aggression and violence. How to be having a calm, interested approach. Show that you are concerned with the patient and you are focused on helping the patient, not insulting him. The another thing we are saying, call the patient by name and walk a little bit with him and find out the cause. That's another thing we're going to do. Call, if the patient is called James, call him, James, come here. We walk together in the compound as you're asking what could have brought the aggression or what could be the cause of the violence. Then after knowing it, we are saying deal with the source of the problem and encourage him to ignore the source of the problem if possible. Encourage the patient to ignore or you deal with the source of the problem. Then next thing we are saying, the patient can be engaged in games. Here you want to occupy the patient's mind with something that can make him busy, and hence will not think of what caused the aggression. So engage the patient in games like table tennis, pool table, playing cards, and these ones will help relax or verbalize, will help the patient verbalize the problem or relax the mind. So that's the fourth thing you are going to do as we manage aggression and violence. So what else are we going to do in addition to this? We are saying it is useful and accessible to explain your intention to the fellow members of staff before going with an aggressive patient. We are saying it is very necessary to first explain. Remember, the client is aggressive. If you don't explain to your fellow staff members, you may lack support. This patient can turn to be against you. That's why we are saying it is useful and sensible to explain your intentions to the fellow members of staff so that they can give in a hand and help you manage this aggressive patient. Then next thing, as we manage the aggressive patient, we are saying physical battle should be avoided as much as possible. In most cases, these patients will want to irritate you, and as they irritate you, may become also angry, and you want to make a physical battle. You want to fight them back. We are saying try to avoid that as much as possible. Don't fight the patient because he's violent, and maybe you want also to come with force. Always try to avoid the physical battle as you are managing the aggressive patient. Then you are saying that the staff should have a priority arrangement plan as to who should do to avoid the situation of many and all of them diving for one limb. So these aggressive patients most times will have to restrict them from doing whatever they are doing. So as a managing team, you have to decide and arrange how you're going to handle this patient by force, but you have to say so and so has to handle maybe the legs, this one will handle the arm, this one will handle this, so that as you grab the patient cannot fight you back. That's why we are saying you should make an arrangement plan as to who should do what to avoid a situation of many or all of them diving for one limb. So that is very important because most times you're going to restrict them from the actions they are doing by force. So that has been aggression and violence as one of the psychiatric emergency. We have looked at how we can manage it, what causes this aggression and violence. We have seen even in some conditions, mental disorders, where we can find aggression and violence. We saw the silent symptoms, and that's how we are ending it. So as we are still having time, we are going to also talk briefly about attempted suicide. Remember, attempted suicide was one of the psychiatric emergencies we saw yesterday. So we are continuing to talk about them. So attempted suicide, we are saying suicide is an attempt of ending one's life that results to death. So if someone attempts to end his or her life, attempt of ending life, we call it suicide. And we shall look at several forms of this suicide, several attempts, and even we shall look at the types of suicide. So I've said that suicide is an attempt of ending one's life that results to death. So we have attempted suicide, which simply means an act of self-destruction that does not result in death. Someone wanted to end his life and eventually it didn't become successful. we say that person has gotten attempted suicide, or he wanted to end his life, he wanted to destroy his life, but it didn't result into death. Maybe it remained at a point of injuries or severe disabilities, but didn't eventually die. We shall completely say that that person had attempted suicide. Then you have another term which we are calling infanticide. And we are saying this means killing your own child. This is common to people who have pubertal psychosis. They normally have this issue of infanticide, and the mother kills the child. So if the mother kills the child or the baby after birth, we call it infanticide. That's another form or another thing in form of suicide. Then we have genocide, and simply means mass killing. Someone decides to burn a house with several people. Someone throws a bomb in a market. We shall say that person has committed genocide, mass killing. A number of people dies at once. Then we have patricide. Patricide, this is killing your father or parents. When someone kills the father, we call it patricide, or even if he kills the parent, we say that is patricide. It's very common with people with mental disorders. They can decide to kill their parents, and if they do so, we say that they have committed what we call patricide. Then there is homicide, and that is ending another person's life. Instead of this person who has a psychiatric disorder, instead of killing his life, he ends another person's life. So the term is homicide, ending another person's life. Then we have another term which is paradoxal, which simply means when a person commits suicide at the time you think he's getting better. Paradoxal. That term is used when the person commits suicide at a time you think he's getting better. The person was improving. You thought now you can leave him to relax, and that's when he commits suicide. So the best word we use there is paradoxal. Then we have patricide, who are two people who are lovers agree to kill themselves. Maybe because you are in true love with someone, too much love, you don't want to lose him or her, and you decide you two to kill yourselves. We call it patricide. So those are some of the terms that are used in suicide. I've talked of attempted suicide. One wanted to destroy his life but didn't result into death. Infanticide, this person kills his own child. Genocide, that is mass killing, killing very many people at once. Patricide, you kill your parent or father. Homicide, you end another person's life other than yours. Then paradoxal, this means the person commits suicide at a time you think he was getting better. And lastly, we have said patricide. Two people who are lovers agree to kill themselves. Maybe because one is sick and one is weak, he wants to live. They say, let's die together since we are lovers. We call it patricide. So we are going to look at reasons why people commit suicide. Reasons why people commit suicide. One of them is to punish relatives. Some of these people think when they commit suicide, they are punishing their relatives. That's one of the reasons why people commit suicide. Others want to relieve relatives and family. You find someone feels as if he's a burden to the relatives and the family members, and in wanting to relieve them from that burden, he ends his or her life. Another thing, people commit suicide for recognition. They want to be known for the act committed, to be known among others. So someone decided to commit suicide for recognition, but eventually he will have died, or he will not die, but will remain with a lot of disability. Then another reason why people commit suicide is to rest. Some people are tired of the earthly problems and challenges, so they are willing to rest and they decide to end their life so that they can rest forever. Then there is hopelessness feelings. Someone no longer has any plan for the future, feels it is all with him about the world. So because of the hopeless feelings, he or she decides to commit suicide. So those are some of the reasons why people commit suicide. So we shall still talk about some risk factors that can make people think of committing suicide. And among the many risk factors, one is marital status. For example, someone has been divorced, has been married, now someone divorces. We talk about widowed, has been having a partner, now the partner is dead, or singles. So with marital status, they try to give out the divorced, the widowed, and the singles. That those people most times are at risk of committing suicide, and I've tried to explain that the one who has divorced will wish to end the life because there is no one who's going to give support, maybe has left a lot of good things with the other man. Then the singles, maybe because of relationship challenges, they can also decide to end their life. Okay, as we continue, we are just having 9 minutes left to end our session. So keep note of that. Next, we are looking at another risk factor, which is gender or sex. And they are saying suicide is more common in males than females, especially for the females. They always do attempted suicide. So attempted suicide is more common in females. But suicide, we are saying, is more common in males than females. But only attempted suicide is more common in females. That's one of the risk factors. So being a male, you are likely to have complete suicide. Then we talk about the age. Suicide is rare in children. It is more common in adolescents and people who are aged 40 to 50 years. Then we talk about religion. We are saying it's low among the Roman Catholic than other religions. So these are results from statistics that religions, especially the Roman Catholics, they rarely commit suicide, but other religions have more members who commit suicide. Then we talk about the socioeconomic status, where we talk about that high risks in people of the highest and the lowest classes. People who are in extremes, the ones who are having a good social status and those who are having the lowest are the most commonly associated with suicide. But those who are in the middle class, they rarely commit suicide. So those are some of the risk factors that can lead to people committing suicide. Furthermore, we can talk about the occupation that suicide risks is higher in physicians, musicians, dentists, law enforcement officers, and insurance agents. There are some of the occupations where people normally commit suicide: the physicians, the musicians, dentists, the law enforcement officers, and insurance agents. Then we talk about the issue of race as another risk factor, or ethnicity. And they are saying suicide is higher or common in whites, followed by Native Americans. So African Americans and Asian Americans are the people who commonly commit suicide. Then also presence of a general medical illness is another risk why people may commit suicide, because maybe he's having HIV and now he's also having a mental disorder, so he decides to end the life. Other risk factors are family history of suicide. If a family normally have members who once committed suicide, it can be a risk to this person also to be likely to commit suicide. Other risk factors, we talk about bereavement. People, after they have lost their dear ones and they feel they cannot live without them, they can also decide to end their life so that they can meet them. Then we talk about alcohol and other drug of abuse. So if someone takes alcohol, this alcohol is going to affect his reasoning. And in the due course, if he's annoyed, he may wish to punish others, as we have seen in the causes of suicide, by ending his life. Other people can commit suicide because of lack of employment. Someone has searched the job for 10 years, can't see it. And because of that lack, he decides to end his life. Then we talk about retrenchment. Sorry for the disturbed network that went off, but you are saying other risk factors that can make people commit suicide. And now we are talking about retrenchment or forced or abrupt retirement. Someone has been forced to retire, and in the due course, he just commits suicide. Other people have severe insomnia. Insomnia is lack of sleep. So someone is always awake, can't get even any sleep because that is severe insomnia. Decides to make himself to die so that he can sleep. So those are some of the risk factors that can bring about suicide. We still have more causes of suicide, and here they are grouped into physical causes, socio-economical factors, mental causes, psychological causes, and there are many. So some of these other physical causes of suicide, and we are going to talk about the physical causes. Here with the physical causes, we are saying like chronic illness, like HIV. Someone may think of ending his life. Other people have stigmatization. Stigma, someone has low self-esteem. He feels he's not worthy to live and not to be seen by others. He wants to be isolated. So in the due course of wanting to always be isolated, when he finds it almost impossible, then he ends his life. Then when you talk about physical deformities, like someone's limb has been amputated, now it is no longer there. Because of that physical deformity, the person may just wish that his life is ended completely, or he or she ends his life. When you talk about socioeconomic factors, someone runs bankrupt, which you are saying bankruptcy. Someone used to have money, but currently has no single coin. Unemployment, retirement, poor housing, those are some of the socioeconomic factors. These factors have given them, but in this case, I'm now trying to group them in terms of physical and socioeconomic, as we are seeing. Mental factors that can make someone think of suicide, like someone who has depression, persistently low mood, someone is devastated, who have talked of alcohol abuse to affect the mental state, personality disorders, people like who have paranoid personality. He thinks other people don't love him. So in the due course, he wants to end his life. We have talked of schizophrenia, because someone has split of mind, sometimes happy, sometimes sad, so has disorganization in the mind. So he can get hallucinations and they command him to end life. People have epilepsy, those who have hysteria, like you have got to always get hysterical fits, since their loved ones are not near, they decide to end their life. When you talk about psychosocial factors, like loss of a dear one, which I call bereavement, failure to achieve a goal, divorce or separation, and disappointments. So next time we meet, we shall talk about methods of committing suicide and how to manage suicide. Those are some of the things that are left. Maybe something else I needed to tell you. We have two types of suicide. We have attempted suicide and complete suicide. If we are asked to mention the types of suicide, we have two types. We have attempted suicide and completed suicide. Attempted self-destruction, but someone doesn't die. With the complete suicide, self-destruction, and the person eventually dies. And those are the two types of suicide. Terms that are used in suicide, be able to know them because they can ask them in objectives of healing, infanticide, genocide, homicide, and so on. Thank you for listening and surrendering your time. This is why I wish that we should end for today's session. And I wish you a good evening. Unless you have a